All right, so again, good morning. This talk covers part of the new book about the history of the Phipps Clinic and about the sometimes discordant relationship between Johns Hopkins and American psychiatry. It wasn't always discordant. In the early years, the leader, Adolf Meyer, who essentially was the Phipps Clinic, was often called the dean of American psychiatry. In modern times, Hopkins Psychiatry has routinely been cited as one of the best departments in the country, even as it questioned the Bible of American psychiatry, the DSM. But the years between Meyer's retirement in 1941 and the modern perspectives-based era, starting with Paul McHugh's arrival in 1975, were not a time when the department was acknowledged as a leader in the field. So why talk about that era and not the better times? One, because the era is little known. It's not hard to find stories about Adolf Meyer, including a whole book published a few years ago about his creation of the Phipps Clinic. And if you want to know what happened during the McHugh era, just look around you. There's somebody who can tell you about it. But there's very little written about the mid-20th century of the Phipps Clinic, and fewer people left to remember it. I see Larry Alessi back there. He's among those. A second reason to focus on it is because this was an interesting period in American psychiatric history. There was optimism that psychiatry could cure society's ailments and individual neurosis. There were new wonder drugs in the pipeline, and there was also factionalism and conflict associated with these radical changes in where and how we treat mental illness. And thirdly, the story of the middle years of the department's history helps explain the uniqueness of the Phipps Clinic and how it has become established as a leader in psychiatry, despite standing apart from the dominant paradigms that have governed American psychiatry, whether psychoanalytic or DSM-based. To summarize the objectives, you should learn from this talk something about how the Phipps Clinic, how the Phipps Clinic helps foster the growth of community mental health, biological psychiatry, and even psychoanalysis, and how these disparate forces interacted to shape a modern American psychiatry, and how the Phipps Clinic responded differently to these developments than other institutions. So just note, I'll have some quotes in some of these slides, and I'll give you the gist of it. I don't expect you to read every word of them, and if you want to read every word of them, they'll be posted online on the CME website. Perhaps the most important difference between the Phipps Clinic and American psychiatry in general has been the Phipps attitude towards the relationship of mind and body. Adolf Meyer's term psychobiology was meant to convey that idea, and the perspectives approach provides methods appropriate to both mind and body. By the time the Phipps Clinic opened in 1913, mind-body dualism in psychiatry had already been seen as a problem, as described in this widely cited essay by E.E. Southard. On one side, there were the biological scientists who were committed to finding the causes of psychopathology in the blots and spots in the brain. On the other were the emerging psychodynamic thinkers who believed that one could find causes and cures for mental illness in the tangles and twists of the mind. Those from one camp tended to disparage the other, or at best to have no way of connecting their ideas together. So Adolf Meyer also thought this separation of mind and body was a major problem for psychiatric thinking because he saw mental phenomena as functions of the body. Mentation and behavior are real objective phenomena, he taught, and are functions of a living organism. So they are therefore fodder for the objective methods of science. Mental symptoms, Meyer would argue, represent disruptions of cerebral functioning, but not necessarily brain lesions, as asthma or nausea might represent functional disruptions of otherwise intact organs. So a scientific approach to mental illness, which psychobiology aimed to be, meant that a brain scientist should consider a person's thoughts, feelings, and actions to be objects of study, and a therapist must not merely interpret mental life, but also take into account its biological functions supporting adaptation and survival. A non-integrated approach that ignored mental phenomena on one hand, or that tried to understand mental phenomena without accounting for their biological functions, would, in this view, either lead nowhere or take the field down blind alleys. The conflict of mind-body integration versus segregation underlies a lot of the ideological turmoil that played out in American psychiatry during its first century. Since the doors of the Phipps Clinic first opened in 1913, there have been, I would say, 4 eras, mostly corresponding to changes in department leadership. The golden age began when Adolf Meyer and Johns Hopkins first linked an academic psychiatry clinic to a general hospital, where new ideas for patient care could be developed, causes of mental illness explored, and new psychiatrists taught to be therapists and not merely custodians. and it ended in Meyer's retirement in 1941. And the next major era for the Phipps Clinic is the Renaissance that began in 1975 when Paul McHugh and his followers came to Hopkins and reestablished it as a leading academic psychiatry center with a new pluralistic approach to psychiatry formulated in the perspectives. The modern era now is arguably an extension of McHugh's Renaissance, as the general philosophy is the same, based on the perspectives, and the faculty and leaders have mostly been trained at Hopkins. There's also been an expansion of research, of clinical reach, teaching, and financial stability. But what about the Middle Ages between Meyer and McHugh? During those 34 years, there were 3 Phipps clinic leaders, 4 if you count Jerome Frank, who served as interim chief for a time, and more than that if you count the years 1973 to 75, when a faculty committee ran the department. And you might have heard the names of these leaders: John Whitehorn, whose portrait hangs in a Meyer conference room, Joel Elkes, whose large expressionist paintings decorate the Meyer hallways, and you might have even heard of the very brief tenure of Seymour Ketty. But what happened at Phipps and in American psychiatry during these 3 decades, from the 1940s to the 70s? So this slide previews the rest of the talk. Besides the great minds doing important work in the department throughout the era, American psychiatry was undergoing a contentious transition from an asylum-based custodial field of medicine to one that had ambitions of treating or preventing mental illness and that was ready to move on from institutional psychiatry. World War II demonstrated that at least some forms of mental illness could be acquired from identifiable stressful circumstances and treated successfully with psychological intervention. The mental hygiene movement, which had informed Adolf Meyer's drive to start the Phipps Clinic, then developed into a national mission to promote mental health for all as the U.S. established the NIMH in the late 1940s. At the very same time as psychoanalytic theory was dominating psychiatric thought in America, some of the drugs we still rely on today, like neuroleptics and antidepressants, were invented and tested. And while these drugs helped many patients manage symptoms well enough to leave the hospital, the big push towards deinstitutionalization came in the early 1960s with the Community Mental Health Act, signed into law by JFK, with a promise to replace state-funded institutions with federally funded outpatient treatment in the community. As the 1960s progressed, the growing mistrust in authority that pervaded American culture also spawned a mistrust of traditional psychiatric theories. New factions sprang up and fought for followers. LBJ's Great Society programs emerged and further provided the means to discharge indigent and disabled patients from institutions to the community without necessarily putting them out on the streets, although that's the way it turned out a lot of the time. Meanwhile, in Baltimore, with the rioting after the assassination of Martin Luther King still fresh in mind, the Phipps Clinic would belatedly begin to confront its undistinguished record with regard to racial diversity. Within the clinic, during those 34 years, there was steady growth in personnel, as illustrated on this slide. You can note the increase in psychiatrists on staff and on the house staff. Psychologists weren't always counted in the survey, but once they were, they also increased in the 1960s. And as this chart shows, the pattern of changes in clinical care measured in patient volume and length of hospital stay, you can see that from 1941 to 1961, there was very little change in the number of patients being treated and how long they stayed in the hospital. And then sometime in the late 1960s, there was a dramatic drop in the length of stay with a large increase in discharges in an outpatient volume. So did this follow from the effect of new medications to get patients home sooner, or was there some other factor? I'll speculate about that at the end. So to get the context for this dive into the medieval era, let's start at the end of Meyer's golden age. Adolf Meyer, in his more than 30 years associated with Phipps Clinic, beginning in 1908 when he was first hired, promoted a theory called psychobiology. Psychobiology, again, saw mind and body as indivisible. Using this theory, Meyer sought to treat mental disorder as a disruption of biological adaptation. Meyer grounded his work in the extensive patient biography, the Phipps history, which provided the data for clinical intervention and research. His department also hosted behavioral scientists like John Watson and Horsley Gant and Kurt Richter. He brought Lee O'Connor, a pioneer of child psychiatry, to Hopkins and supported early work in psychiatric epidemiology and the launch of the mental hygiene department at the School of Public Health. His influence can be seen in the adoption of his concepts into the first DSM several years after his death in the 1950s. Meyer trained a large proportion of academic psychiatrists in the U.S. at one point, and some key figures in British psychiatry, including Aubrey Lewis, who would go on to lead the Maudsley Hospital in London and to play an important indirect role in the Phipps Renaissance in the 1970s. And again, if you haven't already, you should pick up and read Susan Lamb's book about Meyer's path to the Phipps and the early years of the clinic. When Meyer was nearing retirement in 1937, he was honored by a large gathering of his former students at the Belvedere downtown. Many of them came and talked about their work and attested to Meyer's influence on them. At that point, he had trained about 1 in 8 academic psychiatrists in the country. But in the eclectic set of presentations for this event, his old students also demonstrated that his influence did not extend to sharing a common theory or ideology or methodology. They tended to come away from Phipps and Meyer with a scientific attitude and then appreciation for mind-body integration, but without a readily transmitted theory or practice of psychiatry to teach their students, because Meyer never wrote it all down in a form students could understand. So this was Meyer's last class of residence in 1941, and it's appropriately given what we did this morning at 8 o'clock with our group photo. And here right in the middle is Adolf Meyer, standing next to Ted Lids, who would start our consult liaison service and then go on to lead Yale's psychiatry department. And then over there is Jerome Frank, who was a resident back then and still here supervising residents in what's now Dr. Swartz's office when I started at the Phipps in the early 90s. So John Whitehorn came to the Phipps that same year from Washington University, having gone to St. Louis from McLean Hospital 3 years earlier to help start the WashU neuropsych department. While he was the Phipps director, he would go on to lead the APA during a crucial time in the history of American psychiatry, when the power was shifting from traditional asylum custodians to psychiatric therapists. He was, however, never really a student of Meyer and did not adopt Meyer's integrative theory. Rather, he was a psychiatrist involved in biochemistry research who discovered the power of talk therapy and wanted to study it using scientific methods. And Whitehorn didn't invent talk therapy, of course, but he discovered serendipitously while studying the effects of various metabolically active chemicals on lethargic patients with schizophrenia that his informal conversations with patients were more therapeutically potent than were any of the chemicals he was trying out. So he did a control study on conversation, where conversation was compared to biochemicals, and found that patients who received placebo plus conversation showed more improvements than either of the other treatment groups. Whitehorn thought this discovery was the reason he was chosen to lead research institutions like WashU and Hopkins. After replacing Meyer, he didn't abandon Meyer's comprehensive history-taking methods, but he did put less emphasis than Meyer on finding the root causes of a patient's maladjustment, and more emphasis on finding ways to problem solve with patients while getting them to talk about things that made them feel good about themselves. There are several former Phipps residents who've written about this and commented on how they would learn all about Shakespeare or plumbing or coffee bean cultivation from Whitehorn's extended conversations with patients and teaching rounds, but not much about the patient or what was wrong with them. During Whitehorn era, there were some major accomplishments. Leo Kanner first described childhood autism, and Conner's eventual successor, Leon Eisenberg, along with Keith Connors, did some of the first clinical trials of stimulants for ADHD. Jerome Frank launched a 25-year research investigation into psychotherapy that you can read about in Persuasion and Healing. Eugene Meyer expanded the more narrow, analytically focused consult service started by Ted Lids and into a mind-body focused service more in line with Adolf Meyer's thinking. And Adolf Meyer's two behavioral scientists continued their work, Richter on behavioral self-regulation and the biological clock, also on rat extermination, as mentioned in an article in this week's New Yorker magazine, and Gant on how neurosis can be conditioned using classical or Pavlovian methods. So there were some notable figures on the Phipps staff as of 1945. There's John Whitehorn in the middle. There's Esther Richards, who ran the outpatient department for many years. And over there is Leo Kanner, the child psychiatrist, and Horsley Gant on the side. And also in the uniform in the front row is just a few down from Whitehorn is Ted Lids again, standing next to his wife Ruth, and on the other side is Sarah Tower, who I'll come back to in a later slide. A dozen years later, some notable figures besides Whitehorn include Jerome Frank again, who is now front and center and the director of the outpatient clinic after Esther Richards retired. And then over there is Yerv Yalom, who's had great success as an author of books about psychotherapy. Among other things, Yalom has written major textbooks about group therapy and existential psychotherapy, and a best-selling collection of psychotherapy case vignettes called Love's Executioner. He also wrote a memoir called Becoming Myself, in which he revealed that during his residency in the late 1950s, Hopkins Psychiatry was broad-minded but not integrated. It had a split personality. Yalom saw Whitehorn and Jerome Frank as being logical and focused on data, in contrast to the strong orthodox psychoanalytic faction doing consult liaison work in the main hospital. But in the twilight of Whitehorn's tenure, changes in American psychiatry loomed large, as psychoanalysis had become a dominant force that raised concerns within the department at Hopkins might put them in the hands of a follower of what behavioral scientist Horsley Gant termed couch philosophy. Gant expressed his concerns to the search committee as Hopkins was searching for Whitehorn's successor, advising them to steer clear of proponents of psychoanalysis, which he saw as dogmatic and anti-scientific. Meyer, and for that matter, Whitehorn, were both friendly to psychoanalysis. Neither believed it was authoritative, however, as a theory or as essential as a practice. By the time Whitehorn stepped down, psychoanalysts were running most of the major academic psychiatry departments in the U.S., even those involved in biological research and treatment. Hopkins, along with WashU, which again was co-founded by Whitehorn, and Cornell, which was then led by a former Phipps resident and faculty member, Oscar Diethelm, were among the few exceptions. There are several obvious reasons for the success of psychoanalysis versus Meyerian psychiatry. Demographically, World War II led to a large immigration of analysts from Europe who came equipped with well-established doctrines. Their students underwent years of training analysis to learn psychoanalytic theory and practice, and in turn recruited and trained new analysts following the same or slightly updated theories. Meyer's students became leading proponents of mental health and hygiene, leading scientists, even leading psychoanalysts, but they couldn't compete against psychoanalytic theory for influence over their own students. In short, this is likely because Meyer's influence over his students was conveyed personally, mainly by example and dialogue. He taught an approach. One must gather and organize a comprehensive account of how a patient has developed and coped throughout life, and refer to that as a basis for identifying problems in how the patient copes with present social demands. But he did not find a way to boil it down to a coherent theoretical system and practical method to pass down to students. Meanwhile, psychoanalysts had institutes outside of academia that were ensured that the fidelity and propagation of their theories. So in this environment, in 1958, Whitehorn announced he'd be stepping down in 1960. And would Hopkins follow the general trend in academic psychiatry at the time and replace him with an analyst, as Gant feared? Some at Hopkins, as we've seen, distrusted the scientific objectivity of psychoanalytic theory. But strong candidates outside the psychoanalytic establishment were hard to find. The search committee was made up largely of medical scientists, no psychiatrists. Whitehorn was consulted but had few good ideas about a successor, so the committee was open to suggestion. They had little concept what a scientifically oriented psychiatrist would look like because there was so little scientifically oriented psychiatry being practiced. In contrast to Horsley Gant's advice to steer clear of psychoanalysis, at least one prominent Hopkins-trained psychiatrist, then working as training director at Shepard Pratt, thought this aversion to psychoanalysis was a fatal flaw for the Phipps. Lawrence Kuby, a student of Adolf Meyer, he gave one of the presentations at the Meyer celebration in 1937, and then went on to a high-profile career as an analyst, thought the search committee needed to think of itself as a group of pathologists assigned to conduct a post-mortem to figure out why the Phipps had failed, why it had been unable to assert and maintain its reputation as a leader in the field. There was a more even-handed take on the challenge of finding a good academic psychiatrist to run the Phipps clinic from the head of the Johns Hopkins Institute for the History of Medicine, Oswald Temkin. He noted that it had become difficult to say what constituted a state of the art in psychiatry, which he saw in an uncertain position, and noted that there was essentially no internationally recognized science of psychiatry. But he did feel strongly the head of a great psychiatric department should be a clinician. It mattered less to Temkin what his theoretical orientation might be, biological, analytical, or otherwise, as long as he was not so dogmatically beholden to any one philosophy that it would constrict the diversity of viewpoints in the department. 2 years after Whitehorn announced he was leaving, and as he was packing up his office in mid-1960, they still hadn't found anybody for the job. And Jerome Frank, who was stepping in as interim chief, complained to the search committee that the uncertainty over department leadership was causing Phipps to lose staff and prospective trainees. Frank foresaw from this situation a progressive deterioration of our functioning and morale, but still no selection was forthcoming until the following year. So after sorting through scores of candidates, the search committee had disregarded Temkin's advice and selected Seymour Ketty, an eminent basic scientist, but in no way a clinician. As a research administrator at NIMH, he oversaw and contributed major work on the brain and nervous system. Ketty was ambivalent about taking the Hopkins job. First, he declined. Then he talked it over with Aubrey Lewis, who thought it was a good opportunity to raise the stature of science in the profession. Ketty also talked it over with his personal psychoanalyst, Ruth, who in strict Freudian fashion wouldn't give him any advice. Once he finally made up his mind to come to Baltimore, he had a comical but ominous experience. He tried to sit in Adolph Meyer's old chair, and it promptly collapsed under him. The collapse of Meyer's old chair was indeed an omen, as Ketty pretty quickly discovered that the job wasn't for him, because he had a very little interest in dealing with nurses and police and social workers and a whole melange of health professionals, and so he stepped down after only a year. And rather than start from scratch, the dean reassembled the same search committee as before. Lawrence Kuby, still training director at Shepherd Pratt, again offered his opinion and proposed to educate the committee on the importance of psychoanalysis in residency training. Acknowledging that he was still fighting against an institutional antipathy towards psychoanalysis, he still insisted that analysis must play a major role in whatever ambitions Hopkins had for a successful academic department. And he invited the committee over to his house for dinner so he could try to persuade them of that. I'm not sure they took him up on it. The committee member, Vernon Mountcastle, continued to solicit advice even after the committee had come to a decision about Ketty's successor. He met with another old Hopkins hand, Sarah Tower, who had been on the Phipps staff since the 1940s, a neuroanatomist who underwent psychoanalytic training. She confirmed that Phipps had gained a bad reputation in this field because of its hostility to psychoanalysis. Indeed, that others perceived Hopkins as trying to destroy psychiatry as a medical discipline, and that the reputation would deter anybody of first rank from wanting to take the job leading the Phipps clinic. In her talk with Mountcastle, she candidly told him why she thought none of the internal candidates, like Jerome Frank and Leon Eisenberg and Eugene Meyer, might be adequate, and instead suggested several psychoanalysts who she believed were qualified because of their interest in treating severe mental illness. Mountcastle was quite smitten with her and thought she could have been a good candidate for chair if she wasn't already 62 years old at the time. Around this time, 1963, the Community Mental Health Act was signed into law. The mental retardation part of it had been added to make it more attractive to JFK, who had a sister with intellectual disabilities, and that's why the Kennedy is the first K of KKI. Meanwhile, Hopkins' psychiatry leadership was in disarray. The whole time, the profession was crafting and passing the most important psychiatric legislation in American history that promised custodial mental institutions would be replaced by therapeutic centers in the community. In fact, many prominent Hopkins-associated psychiatrists had doubts about the legislation for various reasons. Leon Eisenberg, who was then head of child psychiatry and was later the head of Mass General Psychiatry, foresaw empty promises of change. Joseph Wardis, who had worked with Meyer and later started and edited the journal Biological Psychiatry, saw psychiatry as overreaching into social matters. John Whitehorn, retired by this time, similarly thought psychiatry was out of its element trying to resolve social problems. And Lawrence Kuby feared that young psychiatrists trained in the analytic model would be poorly prepared to work in urban community settings. So whereas in past times, Meyer and Whitehorn had both spoken out as leaders of the profession about the role of psychiatry in the world, Hopkins and the Phipps Clinic had little to offer as a department while the new law gestated in Washington. So fortunately, the second iteration of the Psychiatry Search Committee had an easier time finding a new chief in Joel Elkes. His claim to fame at that point was that while he directed a psychiatric research unit in Manchester, England, he and his wife had published the first double-blinded, placebo-controlled clinical trial of chlorpromazine, demonstrating its efficacy calming agitated inpatients. Elkes had emigrated from England to the D.C. area and worked with Seymour Ketty, who presumably appointed the search committee to Elkes as he was stepping down. I don't know that for sure, but I assume that's why it went so quickly. Elkes' tenure was short-lived, only 10 years ultimately, but he brought in two research heavyweights with his NIMH connections. One was Saul Snyder, who was hired as a Phipps resident and also given a faculty appointment in the Department of Pharmacology as a second-year resident. Snyder went on to make or oversee groundbreaking discoveries in the mechanisms of opioid action and dopamine neurotransmission, and later to found the neuroscience department. And Joe Brady, who was already well known for his work on the executive monkey model of stress and on training chimpanzees for early NASA space missions. Brady worked on the behavioral biology of addiction and sparked the development of the BPRU. So here's Elkes' staff and trainees in the mid-1960s, and besides Elkes, there's Saul Snyder as a resident, and up in the back there is Sanford Wolf, who the same year this photo was taken, helped start the new Gender Identity Clinic, which was the first American center to address discordant sex and gender via hormonal treatment, surgery, and psychotherapy. And that's John Meyer over there, who would later lead the Gender Identity Clinic, and with Chet Schmidt and others start the SBCU, now the Sex and Gender Clinic. Outside of Hopkins, major shifts were happening in the psychiatric world. Factionalism had expanded to an extreme degree, pitting against one another biological psychiatrists, Pavlovians, Skinnerians, rational emotive therapists, orthodox Freudians, Jungians, Adlerians, Sullivanians, transactionalists, Rogerians, existentialists, and Gestalt therapists, and so on. In 1971, Science magazine published a prank that became an influential paper called On Being Sane in Insane Places that sent actors undercover to psychiatric hospitals and purported to show that psychiatrists don't know how to tell a person with schizophrenia from a person who merely said they had a symptom of schizophrenia. While there were major flaws in that study, there was good reason to believe that psychiatrists were bad at diagnosis. In many places, psychiatrists were overdiagnosing schizophrenia based on an informal principle that applied the term very loosely. So one can see this phenomenon graphically in this 1993 paper analyzing diagnostic trends. In 1970, at 4 of the 6 psychiatric centers studied, schizophrenia was diagnosed much more frequently than were major depression and bipolar disorder combined. Over the next 20 years, the diagnostic frequency shifted dramatically, and the midpoint's around 1980 when DSM-3 came out and standardized diagnostic rules. The two that don't match these patterns are first Clark, which has a flatter curve than most of the American institutions and less schizophrenia relative to affective disorders, and is Canadian, which makes sense because of its connection to Great Britain. The British had stricter standards for diagnosing schizophrenia, and so found less of it relative to mood disorders. At Cornell, they had an oddly erratic pattern. Unlike every other US program, schizophrenia was diagnosed less often than affective disorders as of 1970, and also, unlike every place else, schizophrenia rates went up before they went down. So what happened at Cornell? Dr. McHugh happened at Cornell. After training first as a neurologist in Boston and then as a psychiatrist in London at the Maudsley with Aubrey Lewis, he came back to the US and ultimately made his way to Cornell, becoming clinical and training director at Cornell, the large Westchester Division Hospital. As of the early 1970s, Cornell was diagnosing cases more like the British, from whom McHugh had learned psychiatry, than like typical American programs. But he left Cornell in the early 1970s to be chairman at Oregon, and diagnostic patterns at Cornell reverted to the normal American tendency to overdiagnose schizophrenia before changing again with the introduction of DSM-3. I should credit Bill Brakey with pointing this out in a letter to the editor after that study came out. After a few years as chair in Oregon, McHugh came to Hopkins in 1975, and the rest is history for another time. So to summarize, while the Phipps Clinic drifted away from Meyerian psychobiology and American psychiatry in general, spun away from both science and custodial care towards a grand ambition to alleviate mental illness in individuals and society by applying psychodynamic theories, and while new and more effective drugs were being developed, Hopkins linked a scientific approach first to psychotherapy, then to psychopharmacology, and renewed its investment in behavioral biology. Faculty produced enduring research and developed new clinical endeavors in an environment that was at times hostile hostile to the Hopkins way of doing psychiatry. So in the end, what can we learn from this trip into the more unsettled times? So first, during a period of paradigm upheaval, Hopkins psychiatry stayed steadfastly scientific at its core while keeping psychoanalytic practitioners in the periphery, literally in the periphery in the case of Hopkins, as the periphery was beyond the walls of the Phipps building and on the medical wards with the consult service, also in the psychosomatic outpatient clinic that was run by the Department of Medicine. So why in the 1960s did Hopkins steer clear of a psychoanalytically oriented psychiatry chief while other prestigious institutions were seeking them out? One possible answer may be that the unusual arrangement at Hopkins, where the department chair works primarily for the medical school, which is under the university and not the hospital, as the bequest of Johns Hopkins, the man, had stipulated. At a time when most of the leading psychiatric clinicians in America were psychoanalysts, a department chairman search committee answerable to the hospital and run by clinicians or hospital administrators might have searched for a leading clinician to take over, so a psychoanalyst. However, at Hopkins, the dean was less impressed by clinical credentials, so more impressed by a prospective leader's scientific credentials. Hopkins was so committed to this scientific ideal that in 1961 they hired a non-clinician to run the department and thus sacrificed therapeutic excellence in favor of science. However, to be fair, it was very hard to say what therapeutic excellence looked like at the time, and they were getting a lot of inconsistent advice. Although Joel Elkes was more of a clinician than Ketty was, by many accounts, clinical care deteriorated at the Phipps Clinic through the late 1960s, early 70s. We saw earlier that patient turnover rate more than doubled during that time. Maybe this was because of new medications, but by some accounts, medications weren't being used that aggressively back then. It's worth noting here that residency training at Phipps had relied on residents supervising residents and not on faculty supervision. Perhaps turnover increased because poorly supervised residents didn't know what to do with patients if they did stay longer, so they didn't. At any rate, once McHugh and his followers took over, the clinic sprouted subspecialties and reached out to the community, developed strong expert faculty supervision of resident care, and higher standards all around, ultimately a new building named after Adolf Meyer. So I want to thank all my sources for this history, some of whom are in the room. Paul McHugh, whose historical model of American psychiatry I borrowed, the Chesney Archives, where I got a lot of the inside information, readers of the work in progress, and Jimmy, who sent me on this mission, and my wife, Catherine Washburn, who has stood by me on this.
Wow, Dean, that was really, really interesting. I never heard of Sarah Tower before. That was news. I'm curious. I'd like to. A lot
of interesting figures that you pop up here and there.
Yeah, I'd love to learn more. But you know, one thing that occurs to me, which you alluded to, and I'm puzzled by, I never really thought about, is why weren't Jerome Frank or Leon Eisenberg chosen? I mean, they're both incredibly strong.
That's an excellent question. I'd like to know that myself. In fact, I even put it on a slide.
Yeah, I mean, you had really two.
It may be that Frank didn't want the job. Now, Leon Eisenberg had just taken over child psychiatry, I think a year or so before that, or even during that time. So maybe he wasn't really ready to move into adult.
Right, because it was only a couple years later that Mass General decided Eisenberg was good enough to be chair up there. Right. Well, other folks have thoughts or questions? I certainly have other things I'm wondering about. Dr. Taylor.
So the question is about the relationship of the community and around us and our department. My understanding is that it wasn't very good in the 60s. That, you know, as of the time, Dr. McHugh told me, as of the time he took over, we were still shipping indigent black patients from the community out to Crownsville for state hospital treatment, and that was something we turned around. And one of the major things that happened when there were outpatient clinics that served the local area at Hopkins, but we didn't really have a huge outpatient presence in the community. And I think until we started getting CMH funds and started launching community psychiatry and our other programs more in the late 70s.
Thanks. Other folks, Dr. DePaula.
Question from somebody who was there, Dr. DePaulo.
Dr. DePaula.
Oh, no. Joe Coyle, yeah. It's a long legacy of Harvard soaking up people from here and
That's right. That's
putting
right.
them through the ringer.
That's right. Other folks have questions or comments? Yes, Dr. Bienvenu.
I was curious, you mentioned Eugene Meyer's psychoanalytic orientation. And I was curious if we know where that came from.
Well, I think Eugene Meyer was a little less, at least psychoanalytically oriented than his predecessor, Ted Lids. So if you read the kinds of papers he wrote about the consult service, he wrote many papers doing research on the patients they were seeing. He was really more of a mind-body bent than a psychoanalytic bent. He actually wrote a summary that I read in the archives about, as of 1960 or so, what was going on with the consult service, the history of the consult service. And previously they had been very selective. They were only picking the patients they thought they could do some kind of psychoanalytic intervention with between the staff and the patients. And then Meyer came along and said we should really see everybody they ask us to see. Previously, the residents would go see anybody that really needed a psych consult, but it was all mainly just to get them dispoed, not really to do much therapy. Yeah,
Other
Tim.
thoughts? Tim.
That was terrific, Dean.
Thanks.
Thank you. Meyer had championed both Richter and Gant, and I wonder, they survived during this period, but were they getting support?
Well, I don't know how Richter was getting supported. I did find some evidence that Gant was really scrambling for it. I found many messages that Gant wrote to Whitehorn and then later Elkes, lamenting the lack of support he was getting and asking for more. And it was a little frustrating for him, I think. There's a great story that's in the book about how Meyer recruited Gant, which I probably don't have time to get into here, but it was. Do I? Okay, so basically, so Gant had been working with Pavlov over in Russia. He'd gone over to Russia as an internist who was interested in digestion and was interested in Pavlov's work with digestion. But then he sort of got caught onto this whole behavioral science stuff and stayed for years. And he got the attention of some people, prominent people, including H.G. Wells and Alan Gregg from the Rockefeller Institute, who came back and told Meyer about him. And Meyer sent him a letter that expressed some general interest in what he was doing. And then in 1929, they met up, Meyer and Gant, at a meeting in the U.S. And Gant was telling Meyer about how he had interest from the Mayo Clinic in hiring him. And Meyer was just taken aback. I thought I'd offered you a position at Hopkins. But he never really did in so many words, but it was, he thought he did. Anyway, so that got Meyer to give Gant the lab he needed to be able to do Pavlovian type work, and that brought him here.
It's a long tradition playing institutions off of each other in order to get the best possible deal where you are. Well, thanks so much, Dean. Fascinating talk.